Good afternoon, everyone, and welcome to today's webinar. Today is the 3rd of October, and I have the great good fortune of introducing our speaker for today. The title of the webinar for today is Brain Injury Screening and Supports Across the Spectrum of IPV. And I'm pleased to present Russia Nauer, the Director of MindSource from Colorado. Before I go ahead and let her get started, just some brief housekeeping. Today's webinar is being recorded, so that should be uploaded to our YouTube page, the Brain Injury Alliance of Iowa, within the next 24 to 48 hours. So look for that there. If you have to leave early or if you'd like to share that link with someone. And then I do have your all of the attendees on mute and your video is turned off just for the sake of the recording. But if there is time at the end and Russia would like to field some questions, we'll go ahead and do that. Please use the chat box to engage if you would like to make comments or put your questions there. I think with that, Russia, I'll go ahead and hand it over to you.
Thanks, Courtney. Good morning, everybody. My name is Russia Nauer. I'm going to start by describing myself for anybody who's attending that may be visually impaired or benefit from this description in any way. I am a 46-year-old cisgender woman with long brown hair, wearing glasses, and I am calling in from Grand Junction, Colorado today. I am a Colorado native and really excited to get to be here with my friends from Iowa. Although I'm a Colorado native, my father was born and raised in West Bend, Iowa, and so Iowa holds a very special place in my heart. Today, we're going to talk about brain injury screening and supports across the spectrum of interpersonal violence. Some background about me. I began my career working in the juvenile justice field in the year 2000. I began mostly running and working in group homes for youth who were placed out of home due to a commitment to the Division of Youth Corrections in Colorado that is now called the Division of Youth Services. After some time with that organization, I transitioned to being a parole officer and a client manager for youth committed to the Division of Youth Corrections. And after 7 years in that role, I transitioned into the judicial branch. And I worked in the state court administrator's office in the Division of Probation Services. In Colorado, probation is housed within the judicial branch and not the executive branch like it is in a lot of states. From there, I met some of my colleagues in the field, including Liz Gerdeman, Judy Detmer, Jamie Horsfall, Gavin Atwood, and Kim Gorgans. And together, we developed the Colorado Brain Injury Model, which I'll talk to you some about today. And that model has been exported for use in a lot of different states and has been exported for use by the National Association of State Head Injury Administrators. While I was at the Division of Youth Corrections, and some knowledge about how I ended up in brain injuries, having worked in criminal justice, I started noticing that a lot of the youth that I worked with had injuries to the brain. And we would find that out through a process of elimination of the client wasn't really doing great in youth corrections. They were struggling to engage in treatment and in supervision. And we would refer them for a neuropsych exam. And every time the neuropsych exam would come back and say, yes, this kid has multiple traumatic brain injuries and would benefit from these adjustments to their supervision and treatment. When I came over to the state court administrator's office and started working with Judy and Kim, I knew a little bit about brain injuries, but not a lot. A lot of people are pretty aware of, but not everybody, of a 4-year grant that we got here in Colorado that explored the prevalence of brain injuries in the criminal justice system. But we approached that work from the lens of, we're not going to screen people just to screen them. We want to screen them to provide them simple strategies in order to be successful in treatment and supervision. So some of what I'm going to talk about today is some of what we learned from that work. Um, but since we started that project and since we developed what is now known as the Colorado Brain Injury Model, um, we've also really worked to identify how does that work that we did screening people in criminal juvenile justice systems benefit people outside of those systems? How does that work benefit people who are victims of violent crime, victims of intimate partner violence, children, and the family system at large? And before I dive into this presentation, I want to recognize that Jim Pender with Iowa is here on this call with us. And he is your local expert and one of your resources for this work. And at the end of the presentation, I'm going to ask him to unmute and chime in about anything that I left and to talk about any sort of resources that he has to offer or urges for screening that he'd like to extend to the audience. So with that, I'm going to uh, stop rambling through my introduction and we're going to dive into the presentation itself. I think. Let's see. There we go. So first, I always want to make sure that I'm sure that you all understand brain injuries and what they are, but I like to level set with what a brain injury is and how they happen, and offer some caveats about what this means for the domestic violence system and what it means for victims of intimate partner violence. Um, Traumatic brain injuries are when there's an external blow to the head and it causes movement of the brain within our skull. And it's pretty common for people to think that our skull is meant to protect our brain, and it is. But inside our skull, we have bony ridges in our skull. And so when our brain moves up against those bony ridges or hits one side or the other, there's some shearing. In addition, you can get hit on one side of the head and have an injury on the other side of the head. And that's called a coup counter coup effect. And so often people have symptoms of a brain injury that are not quite explained necessarily by where they took the blunt force of the trauma. Because you could get hit in the front of the head and have some visual impairment from the occipital lobe in the back of the head. That's actually very common and very normal. In addition, there are non-traumatic injuries. These are caused by a loss of oxygen to the brain. And this can happen because of choking when you eat, strangulation, like this slide points out, near drowning, drug-related deaths. This is also can be caused by several medical-related issues. What is also important to know is that when we're working with people who have brain injuries, the needs and interventions are similar regardless of whether the injury to the brain is a traumatic injury or a non-traumatic. In general, in the United States, we know that people are most likely to get brain injuries from falls and traffic accidents. So those are pretty common pathways of injury for most folks. However, when we're talking about injuries to the brain, for those who are victims of domestic violence, um, these behaviors that are very common to domestic violence cause a lot of very similar effects. We know that people who engage in domestic violence behaviors not only engage in emotional and behavioral behaviors to coerce and control their victim, but they can often engage in physically violent behaviors, including shaking or strangling their victim, throwing them against walls or against hard objects, kicking or hitting them. What happens when people are victimized with those behaviors is that they have a wide variety of effects, including post traumatic stress disorder, depression, anxiety, and brain injury. The The fact that all of these co-occur for victims of interpersonal violence is also important when we're thinking about how to best support people who have been victims of domestic violence. We've all heard of trauma-informed care, and part of trauma-informed care is assuming that everybody that we work with has undergone some level of trauma. One of the things that I urge people to do that we work with is to also think about brain injury and providing services through a brain injury informed lens. We know that when people are physically abused this way, they're very likely to have had not a brain injury, but multiple brain injuries. We also know that in our own research here in Colorado, that people who are victims of interpersonal violence have not only received brain injuries in the violent relationship, but they're also likely to have had brain injuries before the relationship itself and through those very common pathways of falls and car accidents. They're also likely to have had brain injuries from child abuse. And so there's a history of brain injury across the life course for that person. When we think about the scope of the problem, we talk about in Colorado that at least 500,000 Coloradans have sustained a brain injury or likely are to have a disability due to that brain injury. But a moment ago, I talked about that we know that people that we serve who have been victims of domestic violence are likely to have had brain injuries over the life course. For some, this starts with child abuse. Children who are 0 to 4 years of age are likely to get brain injuries, more likely than some of our other age spectrums. And that is because shaken baby. Adolescents are more likely than other age comparative groups to receive brain injuries, and that's because of their risk-taking behavior. And older adults over 65 years of age are also more likely to get brain injuries, and that's because they're more susceptible to falls. One of the things that's really important to note is that if you've had a brain injury at any point in your life, you're more likely to have a subsequent one. So when we're thinking about how to best serve people that we interface with who have had an injury to the brain, when we're working with people who've been involved in violent relationships, part of the work that we want to do with them is fall prevention work across the life course. The reason people who have had a brain injury in the past are more likely to have one again in the future is because the injury itself does something to adjust our balance. So we're more likely to fall in the future. And when I say we, I count myself in that because I am a person with lived experience with a brain injury. We're more likely to fall in the future. So that's really important to consider when we're talking about how do we best serve people that we work with. In the general population, men are more likely to have sustained a brain injury than women. And again, the leading cause is falls. However, and car accidents are also another leading cause. When we start looking at specialized populations, however, when you look at the right side of my screen here, in some of our specialized populations that have higher prevalence rates than the general population, that's not true. One of those populations where that's untrue is when we're looking at victims of interpersonal violence or intimate partner violence, rather. Victims of domestic violence are more likely to be women, and victims of domestic violence with brain injuries are also more likely to be are more likely to be females. In addition, when we look at people in the criminal justice system, and we look at some of the research that we did both here in Colorado and nationally, it's also women who have the highest prevalence rates of brain injuries. Those women who are on, in one study site in Colorado, we looked at a specific female offender unit. And across all study sites, we had about an average prevalence rate of 45% of people in our study sites had an injury to the brain that were also involved in a criminal justice system. When we looked at that female offender unit, it was 97% of women on probation had a brain injury, a traumatic brain injury. At that time, we weren't even screening for non-traumatic. So again, in some of these specialized populations, while in comparison to the general population, most people who get traumatic brain injuries are men. In some specialized populations where we see higher prevalence rate, the majority of people who get a brain injury are actually women. And this is one of those populations. Before I move on from pretty generalized brain injury information, I just want to invite and see if anybody has any questions.
No questions in the chat yet.
Okay, great. Thank you, Courtney.
Mhm.
So also in Colorado, we work with a professor at the University of Denver. Her name is Anne DePrince. If you have not ever become familiar with any of her work or her research, I highly recommend that you follow her. She issues trauma blogs from her work at DU, and she's also published a book called Every 90 Seconds. It's a really fantastic read. But she started doing some research here in Colorado, and one of the things that they did was they looked at and responded to calls where the police were called for domestic violence, and they queried the women about lifetime history of brain injury. And uh, when they looked at the incident offense, about 50% of those women had experienced a brain injury and an alteration in consciousness from the index offense. However, when they started querying across the life course, up to 80% of women had a lifetime history of brain injury. And this was one of the first things that started cluing us into why it is so especially important to talk to victims of domestic violence about a lifetime history of brain injury. When we start thinking about the spectrum of brain injury and its cascading effects for victims of domestic violence, we know that brain injuries do all of this to somebody who has it. Brain injuries can increase depression, irritation, and agitation, and it can decrease self regulation, planning, organization, judgment, reasoning, and problem solving. I'm sure that everybody in this call can connect the dots about the cascading effects that having a brain injury can have in a relationship that is prone to violence. But let's unpack this a little bit. Within the relationship itself, if within the dynamics of a domestic violence relationship where there is coercion and control being used against the victim, if the victim is experiencing depression and irritability and agitation, that is more likely to set off subsequent violent events within the relationship. If the victim is struggling with self regulation, planning, and organization, judgment, reasoning, or problem solving, that forgetfulness, that struggle to keep up with day to day tasks, that inability to judge a situation may also increase the likelihood of violent behavior within a relationship, and it may decrease the ability for the victim to engage in safety planning, to know how to get out of that relationship, and it makes it harder for them to stay safe within the context of that relationship. And it's already an unsafe relationship. It's already not their fault. So this just sort of inflames everything that the domestic violence victim is going through. In addition, in situations where there is police contact, the victim officer shows up and says, well, you can go to court, and here's how to get the restraining order, and here's all the steps that you can follow. That gets really hard to follow those steps when you have a brain injury and you struggle with organization, you struggle with problem solving, you struggle with planning. So, for example, you may be a victim of domestic violence, and maybe you got a brain injury 2 weeks ago, and you have to take public transportation to show up to court at 1 o'clock to ask for a restraining order to go from temporary to permanent. That task that may already be somewhat daunting becomes even more difficult when you're struggling with planning and organization and problem solving. So, in an ideal world, we want to begin to be brain injury informed from our very first contact from a person who's been a victim of domestic violence in order to set them up for success to navigate a system that we all know has been pretty openly criticized as being a difficult system to engage in if you have been victimized and can be really cumbersome to navigate. In general, we know that brain injuries can cause ripple effects in people's lives. For the general population, regardless of where they got their brain injury, how any other sort of variables that we would control for, um, domestic violence notwithstanding, we know that people who have brain injuries have all of these ripple effects. They're more likely to lose their job. They're more likely to struggle to re engage with employment after their injury. They're more likely to have disruptions at school if they're in school. They're more likely to lose their relationships. They're more likely to have high rates of divorce. They're more likely to lose their friendships. They're more likely to experience disruptions in their family relationships. So, this is a really tough uh, post injury landscape to navigate for anybody. In addition, people who've had an injury to the brain are more likely to have substance use disorders, and the mental health fallouts are more significant. And we'll talk a little bit more about that. Here in Colorado, in a subset of criminal justice involved people who had an injury to the brain, we saw a very marked increase in comparison to the general population in rates of childhood violence, adult victimization, suicide attempts, school suspension, substance abuse, and mental health disorders. Now, I share this because, again, not that I am alleging in any way that people who are victims of intimate partner violence, rather, are necessarily comparable. But when we look at the general population of those with brain injuries, and then we look at some subsets where there are higher prevalence rates of brain injuries within that group, we're likely to see more cascading effects. We're likely to see higher rates of detrimental outcomes. And my guess is, without having done any specific research specifically with this population, that this is likely to look very similar. That victims of domestic violence, we know from our work in a study site of female offenders in probation in Colorado, they were more likely to have experienced childhood violence and they were more likely to have experienced adult victimization. In addition, we know that the mental health fallout is very significant for victims of interpersonal violence, but just generally amongst people who have an injury to the brain. People who have had TBI, if they have never had a mental health disorder in the past, are more likely to experience detrimental mental health effects within 1 year after their injury. That includes having depression, mania, PTSD, aggression, panic disorder, phobias, and psychotic disorders. So we can pretty easily connect some dots here that for people who have been engaged in a relationship where there is coercion and control used against them, where there has been violence used against them, that they're likely to have be higher risk for having had a brain injury. With within that context, they've been in this abusive relationship. They are probably very likely to have these post-injury effects. In addition, Survivors of brain injury are more likely to experience hopelessness, suicidal ideation, and attempt to commit suicide. Um, the suicide after effects of brain injury are also very starkly pronounced in the brain injury community. This pronouncement exists for 15 years post injury. And one of the things that I like to draw a comparison to, because this is very significant, is that the only other time in a person's life where they are this at risk to die by suicide or attempt to die by suicide is if somebody in their close personal circle or an immediate family member dies by suicide. So, uh, for the people that we work with who are involved in the domestic violence system and have been victims of intimate partner violence, one of the other ways that we can best serve them from the very beginning is to assess for risk of self harm and to begin safety planning around that, not only immediately, but on an ongoing basis. In addition to that, there's a lot of substance use and abuse that is related to brain injury. There's often a question about whether that is due to the brain injury, right? Is the brain injury the precursor for the substance misuse, or does the substance misuse cause the brain injury? It's both. It's a pretty symbiotic relationship, unfortunately. And so this chicken and an egg cartoon does a pretty nice job of illustrating that. But um, people who abuse substances are at higher risk for getting a brain injury. Their judgment is impaired because of the brain injury. They're more likely to engage in risk-taking behaviors that would then cause an injury to the brain. They're more likely to drive while impaired and then get a brain injury because of that potential car accidents. They can overdose, lose oxygen to the brain and get a brain injury that way. So all of that can happen. On the flip side, if you've had a brain injury, we also know that that community of people who have not misused substances prior to their injury are more likely to after the injury. And there's a whole host of reasons for that. And some of that really includes the chronic pain that people experience after they've had a brain injury. That can include both physical whole body pain and headaches. But there's also a lot of physical manifestations of the brain injury, such as light and sound sensitivity, that just make day to day life less comfortable post injury. And that sometimes drives people to misuse substances. So before I go on and continue to talk about screening and its importance, I want to pause and see if there's any questions in the chat again.
No questions.
Okay, thank you, Courtney. So what I'm about to share is due in no small part to the work that has been happening in Iowa with Jim Pender and his team. So again, I want to pause and thank him for being here. Thank him for everything that he's shared with us, and make sure that you guys know that you have such a great resource right there in Iowa. It's almost as great as West Bend itself. When we think about screening and brain injury across the spectrum of intimate partner violence, and we try to think about it from a family systems lens here in Colorado and in Iowa. You guys have very shared philosophies on this. It's just so fantastic. The first thing that I like to talk about is we always want to screen a victim of domestic violence for a lifetime history of brain injuries. Again, remember, this could have started in childhood through childhood maltreatment. People could have had brain injuries from car accidents, falls, very common causes. They could have been involved in the military and had blast injuries, right? All of that. And now they are in adulthood and involved in a violent relationship. So the likelihood of them having had a brain injury is increased by nature of the relationship that they're involved in. So we want to screen to make sure that when we're working with them, we're really using that brain injury informed lens in order to provide them personalized, tailored strategies. And I promise I'll get there. Um, but domestic violence doesn't sort of happen in isolation of anything else. Typically, domestic violence occurs because it's a multi-generational problem. So we want to make sure that we intervene as early as possible in interrupting that cycle. We know that if people have an injury to the brain, it makes parenting much more difficult. One of the reasons that it makes parenting more difficult is due to impulsivity. So it's harder to stop yourself from snapping at your child, from hitting them. It's also more difficult to control your negative emotions. And because of that, you're more likely to misuse alcohol or drugs. We just talked about how you're more likely to do that regardless of your relationship status or your lifetime history of any other family mistreatment, childhood abuse, the health of your current relationship. You're more likely to abuse substances post injury no matter what. But if you're a parent and you've been in a unhealthy relationship, you have a traumatic brain injury or a non-traumatic brain injury, you're abusing substances, it makes parenting even harder. For people who have an injury to the brain, their processing speed is also slowed way down. Without understanding that they have a brain injury, that may be something that we miss, that we blow right by. I know that there's a lot of times that I worked with clients and I didn't know that their processing speed was slowed down, and I relayed information at a pretty fast clip. However, when somebody's processing speed is delayed, they may not know it, they may not tell you. That's a hard thing for people to admit sometimes. It's hard for people to ask you to slow down if you're a professional that they're working with, especially if you're a professional that they just met. So, one of the things that comes with that is difficulties processing information. So, it can be hard for people to parent their children if they have an injury to the brain because they may not be able to keep up with the demands of the court, what their caseworker is telling them, what if they're involved in criminal justice, what their probation officer is telling them, what the school is telling them they need to do with their child, what the social worker that's involved with their child is telling them that they need to do. All of that may be really tough for them to keep up with. So whether or not they're involved in any sort of formal system, likely their kids at least involved in school. And so being able to keep up even with those demands can be difficult. In addition, people who have an injury to the brain often struggle with memory impairment, short-term memory impairment, sometimes even longer-term memory impairment. That means that they forget important dates, excuse me, important court dates, school dates, doctor's appointments. They forget requirements of the court. They forget requirements of their caseworker. They forget school requirements. They struggle to remember what their kid is supposed to do at school, post appointments. So it makes everything much more difficult. And then there can be executive functioning issues. That can lead to things like neglect, and difficulties being able to prioritize their child's needs above their own. So we're thinking about why it's important to screen parents. We also want to think about what are the unique vulnerabilities for women who have an injury to the brain. Personally, this is always the most difficult slide for me to present on, being a woman and having my own history of brain injuries. But these unique vulnerabilities are very real. and present a very, very important pressing need for us to screen, especially women who are involved in our system of domestic violence, regardless of whether they are the perpetrator of the incident, because men can be victims of domestic violence too in cis hetero relationships, or if they are victims of domestic violence. This planning and screening also needs to happen not only immediately post event, but over the life course of our work with that woman. The reasons for that is because women have vulnerabilities immediately following the incident and over their life course that present themselves that are not always as present or present with men. Women have more post concussive symptoms than men do. They have higher rates of long term disabilities. They experience poorer health, poor injury, post injury, rather. They struggle more with cognitive deficits. Women have more post injury affective difficulties. And specifically, one of those is suicidality. And remember when I talked earlier about the risks for all people with an injury to the brain when it comes to self harm, suicidal ideation, and dying by suicide? This is especially pronounced for women. Women are more at risk for early onset dementing disease when we have a lifetime history of brain injury. And what also happens is that women report that they are more likely to not receive medical care post injury, and that they're more likely to face structural and financial barriers. We know that women who are victims of intimate partner violence are more likely to struggle engaging with the systems that are set up to support them. The systems are cumbersome and difficult to navigate. That in a lot of our communities, especially if they're rural or frontier, there may not be enough there to help them, right? Like they can be pretty there can be resource droughts in some of our rural and frontier communities, at least in Colorado. I have to assume it's the same in Iowa, but maybe it's not, which would be fantastic. Um, but we also know in general, victims of domestic violence are more likely to face structural and financial barriers. They may have to walk away from their home. They walk away from a second income, maybe the only income that is there to support them. And if they have children, their children. So this gets especially pronounced when we're looking at working with victims of intimate partner violence who also have an injury to the brain. So I feel like I've made the case for why it's important to screen victims of domestic violence, and most likely those victims are women. And often in those relationships, children are involved. It's also important to screen the children and keep an eye on them as they develop across the life course. Children who are raised in homes where domestic violence is present amongst their parents are more likely and more at risk for child maltreatment and child abuse. One of the things that I get asked all the time is how is it that kids who have a history of brain injury are missed? They're in school, they go to the doctor all the time. How is it that their brain injury gets missed over and over again? And part of the reason for that is because of these building blocks. These are the building blocks of development. This is how a kid's brain develops over time. So oftentimes the purple block is highest, last to develop part of the building block. Orange is first. So oftentimes the effects of the brain injury are things that we would not expect to see a child have developed yet. So if a kid gets a brain injury when they're 5 and 6 or 10 and 11, they may not have yet hit developmental milestones that would lead us to assume that they have that social emotional competency or that they have developed that cognitive ability and reasoning. We don't notice that they may have missed those milestones until they're older. So, for example, in this slide, let's say that a kid's brain injury impaired their attention. We don't notice it until they're 18, 19, 20, when they're struggling not only to have those reasoning skills and that social emotional competency, but that they've struggled to develop it because one of those building blocks has been missing. So not only is it important to screen them, it's also important to not disregard the findings because, oh, it doesn't look like they have any of those ongoing effects of the brain injury because of their developmental age. It's important to watch them and their development across a life course, keeping the brain injury in mind. Brain injuries in childhood come along with a set of their own cascading effects, just like what I shared earlier for the general population and for the cascading effects for women and people who are involved in violent relationships. Kids who have brain injuries often experience impaired executive functioning. They may struggle with declined or stunted cognitive abilities, which means that they've developed them up to a point, but that they struggle to get more advanced or nuanced cognitive ability skills. They're more likely to be victimized by their peers, bullying, assault, aggressive behaviors. They may struggle to adapt to new or changing environments. So it's harder for them to change grades. It's harder for them to change schools. If they have a change in a teacher or a coach or living arrangements, it may be more difficult for them if they've ever had an injury to the brain. And finally, they may struggle with forming healthy attachments. That means that they may struggle bonding with their teacher, bonding with their coach, making healthy relationships with their friends. A lot of these are also risk factors for being involved in juvenile delinquency. So again, it's really important that we're not only able to screen that youth for that brain injury, but be able to pay attention to how it may affect their day-to-day life. So before I move on and talk about what do we do with all of this information, I want to ask and see if there's any questions.
No questions.
Okay, thanks.
Mm-hmm.
So you've heard me talk a lot about screening and using a brain injury informed lens. And really that's the first step is we want to screen, we want to provide simple strategies, and we want to engage people with sustainable services. That brain injury informed lens is assuming that when we're working within a system of domestic violence and intimate partner violence, that we can assume that the victims that we're serving have a brain injury and setting up our systems to be responsive to that. But it doesn't mean that screening isn't important. We still want to screen because without the screening, it is really difficult for us to connect people to those sustainable services, which is what the Brain Injury Alliance of Iowa does. So there's some really important questions to ask when you implement screening. You want to know who are you going to screen? How are you going to modify your programming? And you want to screen with a purpose. One of the things that we learned here in Colorado through screening victims of intimate partner violence here in some of our local shelters is that people not only screened positive for lifetime history of brain injury, but in our Colorado model, we have what's called the symptoms questionnaire. The symptoms questionnaire queries about common cognitive bothersome symptoms, and victims of domestic violence often score pretty high on all of those symptom questionnaire areas. And I'm going to get into those in just a second. So one of the conversations we had was, is it important actually to even screen for that lifetime history of brain injury? And again, the answer is yes, it is. While the symptoms questionnaire can let us know where people are experiencing bothersome symptoms, We want to know about that lifetime history of brain injury to make sure that we're screening with a purpose in order to connect them to those lifetime sustainable supports that exist across the spectrum, um, for children, for women, for men, for all people who have an injury to the brain. So, if you can screen and you know about a lifetime history of a brain injury, fantastic. Um, I think Jim is here still, and he will be able to talk about what resources you have to you in Iowa. But these are some common areas of bothersome cognitive symptoms that people experience post-injury: memory, attention, impulsivity, organizational issues, physical sensory issues, delayed processing, and language issues, and mental inflexibility. But there are simple strategies. When I'm talking about building this in and the importance of screening, uh, this comes along with we want to screen in order to help people be able to find success in new ways. And this is not difficult work. We've designed all of this with the hopes that it provides some really simple outlets to be able to help people find relief and success going forward. So you will have access to these slides after this presentation, but I'm going to go through the strategies um, for everybody. So we're looking at working with people who have impaired attention. We want to make sure that we pull things down and work on one task at a time, that our instructions are brief and simple, that we engage the person with whom we're working in planning so that we know that what we're working on is realistic and they're engaged in it and they're motivated to do it. It's not us creating a plan for them, but it's something that's being created together. We make sure that they're paying attention by keeping eye contact, using cues, asking follow-up questions, and we may want to create a nonverbal cueing system, which is, it can just be pretty simple hand signals even. Again, you heard me talk about delayed processing speed earlier, but some of those ways that we can help people who have delayed processing speed is to give them additional time to review information, speak slowly and clearly, ask questions to make sure that they understand the information, and ask them to repeat to you what you just shared with them. Use checklists, provide written cues such as first do this, then this, do this. So 1, do this, 2, do this, 3, then this, and offer assistance when completing forms and checklists. For people who may struggle with short-term memory loss, you want to make sure that you repeat and summarize information. You want to provide written information. And with some people, it's helpful if they take their own notes. You want to review new information frequently. Help people use reminder systems such as written planners and electronic planners and reminders in an electronic calendar. You want to teach chunking, which is taking a large amount of information and providing it in chunks. So first this, then this bit, then this bit. You want to stick to routines as much as possible, such as I'll meet with you every Wednesday morning from 9 to 9:30, and keep it very simple and easy for people to remember. Keep information relevant to them, bringing in extrinsic information that is sort of superfluous to that not superfluous, that's like doesn't matter to the conversation, like the word superfluous right there. Leave that out. And you want to practice and reinforce strategies until they become routine. For people who may have sensory motor skill deficits, you want to make sure that you keep the environment quiet, keep lights dim, turn off overhead lights whenever possible. Overhead lights can really lead to people's fatigue or headaches, and you want to schedule rest periods and breaks. For people who may struggle with social pragmatics, you want to make sure that you provide concrete, tangible, understandable feedback. People with social pragmatics difficulties do not understand sarcasm or metaphor, and you want to make sure that you role play whenever possible. For those who may struggle with receptive language issues, you want to make sure that you are direct. Again, you want to avoid sarcasm and metaphors. You want to give time for people to process what you've shared. You want to provide instructions slowly and one at a time. You want to repeat and rephrase when it's appropriate. You want to ask for people if they've understood what you've shared by having them repeat back. And you want to make sure that you let the person know that you value their feedback, their input, their thoughts, and their feelings. For those who may struggle with expressive language, you want to make sure that you redirect the person when they're off topic. You want to provide opportunities for them to practice appropriate expression of emotion, feel, and feeling. You want to, again, use role play to practice that. You want to teach them how to rehearse silently in their head before sharing verbally out loud. And you want to make sure that you're patient and give time for the person to understand as they develop that skill. For those who may struggle with attention deficits, you want to make sure that you encourage them to focus on one step or task at a time. Ask the client to repeat instructions to you again to check for understanding. You may want to underline or highlight pertinent points. Again, use written and electronic checklists and reminders. Chunk information by breaking complex tasks up into smaller doable tasks. Use color coding. Help them get started and repeat instructions or directions in multiple ways. For those who may struggle with reasoning, you want to point out possible consequences of decisions so that they can think through things from all directions. Speak concretely. Again, avoid sarcasm and metaphors. Avoid open-ended questions. You want to be very clear about the expectations and the consequences, which is if you do this, then this could be the outcome. If you do this, this could be the outcome. Consequences are positive and negative. So you want to point out both of those. And you want to continuously lean into and identify a person's strengths. For those who may struggle with mental inflexibility, you want to, again, be very routine and practice those routines. You want to help prepare them for any transitions. You want to help them in identifying and developing alternative plans. So if this goes wrong, then this is what you can do instead. Help them prioritize tasks, goals, and break those down into smaller, tangible tasks. Again, this is a different way to practice chunking. And you want to be respectful to provide you want to provide respectful feedback when you identify that they may hit a roadblock or a problem area. And again, help them develop an alternate routine or strategy. For those who struggle with emotional behavioral issues, you want to work with them to help minimize any anxiety. And one of the ways to do that is to avoid focusing on their deficits and instead focus on their strengths. You want to promote self-awareness. As a professional, it's important to make sure that you don't interpret any lack of emotion as a lack of interest. Suggest breaks when appropriate. Help them develop mindful activity routines. And you want to help them engage in social interactions that will provide them with positive experiences. In addition to that, those are all of the ways when I talked about being brain injury informed, you heard me say several things over and over, such as chunking material, practicing routines. That is how you can create a brain injury informed program, is to just build that into your day-to-day way of being as a program. In addition to that, you want to make sure that you refer people for ongoing resource facilitation with the Iowa Brain Injury Alliance, and they can help you with that on an ongoing basis. And with that, I'm going to turn it over to Jim really quick to talk about how he can support you and take any other questions you may have.
Thanks, Russia. Can everyone hear me?
Yeah.
Great. It's great to be here. Let me see if it's going to allow me to. Uh, Courtney,
Do you
can
want
you
me to
let,
stop sharing?
yeah, if you can give me the driver's
Want me
seat.
to make you co-host, Jim?
Sure.
All right, sir. There you go.
Okay, I'm going to share my screen real quick. So, yes, my name is Jim Pender. I'm with the Iowa Department of Health and Human Services. I work in the Public Health Division. I've been with Iowa HHS, well, gosh, probably all total about 20 some years. But the last 5.5 years, I was with Legacy Public Health until our merger. I am project director for a federal traumatic brain injury grant through the Administration for Community Living. It's the ACL TBI grant. Our primary focus in that work is we're actually looking at the child welfare system. We have a pilot project in Eastern Iowa where we're looking at caretakers who've had substantiated child abuse or neglect assessments and looking at their lifetime history of brain injury and how we can work with that system to integrate brain injury awareness in that system. I know our time's short, so I'll be quick, but just wanted to share with you if you can see the screen that says brain injury. What is a brain injury? You may be familiar with Your Life Iowa. I'll try and drop that into a link to that in the chat here in a minute. But or if Courtney, if you're able to do that. But we have on Your Life Iowa just lots and lots of information about brain injury, and it's just so important to be brain injury aware and having that lens. Early in my career, I did a lot of work with individuals who were homeless, had no idea that probably better than 3/4 of the folks I was working with had a lifetime history of brain injury. If I did, I would have done things a lot differently, and I think our outcomes would have been a lot different, a lot better. But just wanted to share with you briefly. Russia had shared about the importance of screening for lifetime history of brain injury, and we have a little bit of information there. But wanted to draw your attention down here to the lower middle part of this homepage. We do have Iowa, with the assistance of our Brain Injury Council, Advisory Council on Brain Injuries, in 2019, before the pandemic. We worked with Dr. John Corrigan at the Ohio State University to modify the Ohio State University Traumatic Brain Injury Identification Model, which is a pretty simple 4-question screening tool. We added in what's unique, specific, I should say, specific to Iowa. Iowa recognizes non-traumatic brain injuries for the purpose of uh, brain injuries on the home and community-based brain injury waiver. Things like stroke, epilepsy, brain tumors, but probably something you may not be aware of, child maltreatment syndrome, which is a diagnosable brain injury in the state of Iowa. So we have this tool on here. If you have interest as a provider to use this screening tool, you'll see on the screen there the brain.injury@hhs.iowa.gov. Just email me, Jim Pender, at that, and we can, as a provider, get you set up to use that screening tool. It's pretty simple. There's instructions on how to use it. I'll note that that's available for ages 13 and up. We worked with Dr. Pat Sample at Colorado State University, have an evidence-based screening tool for kiddos age 5 to 21, and that's a 3-question screening tool. It's not diagnostic, but it certainly points you in the right direction. And then next to that, you'll see the Mayo Portland Adaptability and the Symptoms Questionnaire. Russia mentioned the Symptoms Questionnaire. We have that available for you to use electronically. It's really pretty slick. You just go in there and it'll help identify functional limitations. And I want to say 7 or 9 life domain areas. And when you're done, it'll send results right to your inbox, as will the screening tool. The results, along with tip sheets from some of those different types of functional limitations that Rush identified, comes right to your inbox. And then we have additional information about the Brain Injury Alliance of Iowa. They're a key resource for us here at Iowa HHS, and they're neuro resource facilitators who can work with your agency to provide technical assistance and work with you on complex cases and help you work with individuals who've experienced one or more brain injuries to develop those person-centered plans, which are so important to determine treatment outcomes success. And then later, a little lower on here, we have just a lot of excellent resource information. A book that, again, this comes from Ohio State University Accommodating TBI booklet, which gives you great resources on how to modify your treatment plans and just all sorts of other information. I know we're at the top of the hour, even a minute after, so I'll stop there. But if you want further information, just reach out and be glad to assist you.
Thank you, Jim. Russia, it doesn't look like there are any comments or questions. I just wanted to say thank you for making time to carve time out of your busy schedule to come and talk to us. What a wonderful presentation. Jim, thank you for hopping on to add to it. This was really great. As I mentioned, this was recorded rather, and we will share this on our YouTube page here in the next day or so. Yeah, thank you again, everybody, for being here, and thank you again to our presenter. Really appreciate your time.
Thank you so much for having me. And Jim, thank you so much for sharing your local Iowa resources.
Yep.
That's really fantastic. I'm glad you're here today.
Very glad to be here.
Wonderful. Well, thank you very much. I'll go ahead and stop the recording. Russia, you have a really great rest of your day.
I will. You too. Bye, everybody.
Bye.